Good afternoon, everyone. Thank you for joining us today. I am Melissa Hart, Program Manager of Immunization Initiatives at the Partnership for Maternal and Child Health in Northern New Jersey. Today's presentation is part of our Power to Protect New Jersey campaign. Power to Protect New Jersey is a collaboration with the New Jersey Department of Health to raise statewide awareness on flu vaccination. Everyone attending this meeting will receive our updated toolkit with social shareables to help promote flu vaccination. Also, please check out the Power to Protect website to become part of the New Jersey Influenza Action Group to receive monthly newsletters related to flu. At the end of this presentation, there will be a question and answer portion. Please type all of your questions in the questions tab. And now, without further ado, it is my pleasure to introduce you to today's presenter, Dr. David Cennimo. He is a graduate of Rutgers, New Jersey Medical School, where he has also completed a combined internal medicine pediatric residency, internal medicine chief residency, and fellowship in both adult and pediatric infectious disease. He is currently practicing a clinical infectious disease and infection control at the VA New Jersey healthcare system, where he is also the Associate Chief of Staff for Education. He continues to pursue his passions for medical education as core faculty in multiple programs and an Associate Dean for Education at NJMS, where he is an Associate Professor of Medicine and Pediatrics. His clinical foci range from HIV, tuberculosis, emerging pathogens to vaccination implementation and infection prevention, including as a consult to the New Jersey State Department of Health. Please help welcome Dr. Cennimo, and we are excited to hear your presentation today.
Thank you very much, and thank you everybody that's giving up their lunch hour to log in and watch this. Appreciate the kind introduction. At this point, I have to say officially that all of these slides are mine, and the opinions expressed are mine. They may not exactly represent the official opinions of the Department of Veterans Affairs, the federal government, the state of New Jersey, or Rutgers University. And after I said that, for all the legal stuff, you'll see that every slide has a reference, and it very much does represent the official opinions of the federal government, because I rely very heavily on our CDC guidance for vaccination. These are the objectives that we're going to talk about today, and plenty of time for questions at the end. This is sort of a mixed presentation, some cutting edge medical data, a lot of epidemiology, but at the end of this, I really should have said the real objective is every person over the age of 6 months should get an influenza vaccine. We desperately need that to happen. I'll show you some epidemiologic data in a couple slides. And hopefully, if I do this right, you're going to feel somewhat empowered and have some more data on how to convince people to do that. Because the biggest problem that we're seeing right now is low level of vaccination, and we will never try to get ahead of this epidemic without that. So in case anybody was confused, there's a lot of influenza going on right now. So across the country, we have seen, and these are data from CDC, significant amounts of influenza, especially in the South. It started very much in the South, but almost the entire country is in the throes of the flu epidemic. I'll show you some data from New Jersey in a few slides, but this is new in some ways for us. And it's new because of two things. One, we're not very used to having influenza this early in the season. We think about the flu season, we think about fall, winter, we certainly start the vaccine campaigns in early fall, but I'll show you some data that it's usually a later winter thing, especially on the East Coast. So it's early. The other thing is, we kind of forgot about this because the data during COVID-19, we really didn't see a tremendous amount of influenza. I think that was probably twofold. There are some suggestions that COVID-19 as a virus displaced flu from the community, but certainly we also learned that things like staying home from work, wearing a mask, washing your hands obsessively, social distancing, etc., worked for the SARS-CoV-2 virus, but worked for all respiratory viruses. So we really saw a dramatic decrease in everything. If you're following these data right now, we see respiratory syncytial virus really came back with a vengeance even faster than influenza did. So we're back, if not worse than past years. And some people have been sort of taken by surprise. And I think that's another aspect of the public health education we didn't really consider. Flu is back, as I said, flu is severe. Again, these are CDC data, and you can see that we're having significant numbers of influenza cases. We are seeing mortality, 9.7% attributable mortality right now. The mortality data always lag because it takes a while to figure that out, to attribute the mortality. And, 20,000 people almost admitted in 1 week in the United States with influenza. This is burdening our healthcare systems. We all have probably heard these stories of hospitals being jammed to the rafters, 300 people waiting outside an emergency department, et cetera, et cetera. This is what we're seeing. I very much check the New Jersey report. So the New Jersey Department of Health, if you are into the epidemiology of this, does a weekly flu surveillance report. And it's influenza, but it's all respiratory viruses. Actually, I'll show you those data in a second. And the reason I'm showing you this is we are at high. New Jersey is uniformly high levels of influenza, but this is the timeline. So this is the 52nd week of the year, so that week right up before New Year's. You'll see we are not used to being high this fast. So the 2020-2021 year was the anomaly because this was the height of COVID and we really didn't see influenza. But our influenza tends to be later. Nationally, the United States data tends to go west to east, south to north as influenza peaks. So again, this is earlier than we were anticipating. Like I said, state of New Jersey, uniformly high. 44,000 cases had been reported as of last week's data. And so if you're out and about, you are coming into contact with flu. Something that we all have to tell our patients. You're not really able, unless you are taking yourself out of society right now, to avoid influenza exposure. If you're working anywhere near an emergency department, far and away, more and earlier cases and flooding of the emergency departments than we've ever seen. Now, I think this is probably multifold. So certainly we're seeing a lot of influenza. And if you notice, this is the highest 3 flu seasons is the solid gray line. So we're outstripping those peaks. But if you think about it, people are primed to be worried about influenza-like illness. They're primed because of COVID-19. So fever, cough is going to likely, and I don't really have the data to say this is conjecture, but likely engender more hospital and doctor visits than it ever has in the past. And we're seeing across different states much more testing. So some of this is an artifact that, we probably will have the best or most accurate influenza numbers this year than we've had in decades because a lot of the numbers were always estimates. But it is, really recapitulating all of our lived experience in healthcare right now that everybody seems to have influenza. And I always think it's important for us to be able to talk to our patients about the severity of influenza. So a lot of times people say, oh, I get the flu every year. And then I want to joke with them and say, you've probably never had the flu. Because if you've ever really had severe influenza infection, it is not a head cold. It is not something that you think you got every year. High fevers, complete prostration, diffuse myalgias, it really is painful, and it's something that none of us really ever wants to do. 10%, let's call it about 10% of the US population is infected with influenza every year. And that is concerning because, not only do we have this large burden of illness, but this is still a significant contributor to death. And it really galls me in public health and infectious disease to have one of the top 10 causes of death every year be something that, if not being prevented by a vaccine, would be significantly modified by a vaccine. So I spend a lot of time trying to explain to people, especially if they have specific comorbidities or other high risks, this is for you. You might not be the person who shakes this illness off. We'll see some of those risk factors in a second. So what about this vaccine? So as you know, we have a flu vaccine every year. You know, the holy grail, if you will, is a universal flu vaccine that is durable, but we don't have that yet. And the way influenza vaccination works is, unfortunately, it's a series of educated guesses. So every year at the WHO in Geneva, pretty much everybody who's famous or influential in flu research gets together and tries to prognosticate what viruses will circulate, because every virus is a little bit different. COVID-19 is, with its variants, keeps reminding us of viral change. The flu vaccine from last year, the virus has changed a bit. And so we try to make a vaccine that is going to be optimized for what we think will be the viruses circulating that winter. But a lot of these vaccines take weeks and weeks to make. Many of them are grown in eggs. And so this is like a months long process. So they actually set this bet in February for distribution of vaccines 6 months later in August, September. So part of it we have to always admit is, how good was the guess? How good were they at setting this bet? And some years better, some years worse. For vaccines this year, these are the components. For people who are into this, we very much sit and wait for the votes to come out. What I'm highlighting here is the updated, meaning that this was a significant change in components from last year. At this point, all of our vaccines are quadrivalent, so they have 4 different subtypes in them. Influenza A, H1N1, and influenza B, H3N2 are the 2 most commonly circulating influenza viruses. In past years, we've actually seen sort of 2 peaks, an H1N1 peak and an H3N2 peak. And then there's 2 influenza type B. These are less common. They tend to just sort of peter through the entire time, but also important to cover. And you'll see now that we're showing egg-based vaccine, which is the majority of vaccine made, versus cell or other recombinant technology based. And the reason that there's a difference at this point is it was recognized that some viruses grow really well in eggs, but not really well in people, and vice versa. So the ones that are used in the egg-based are really optimized for good growth in the egg so that we can get a robust immune response. Anybody looking for the final word on the influenza vaccine, I direct you to this MMWR. These are really this is the source of most of the data of what you're hearing about today. And there's a couple new things this year. One of the new things, if you're taking care of people who are older, age over 65, there is a preference to using high dose vaccine or adjuvanted vaccine. Admittedly, for years, most of us who practice infectious disease or take care of patients that have immunocompromise, we're trying to direct our patients into that vaccine. For my mother, every year she would call me from the supermarket and put the pharmacist on and ask, which vaccine am I supposed to say yes to? And I would always talk to the pharmacist. What do you have that's either adjuvanted or is high dose? Because I think it would be better. I think we have enough data now that the ACIP, which is the Advisory Committee for Immunizations, has listed a preference. Now, I always point out that's a preference, it's not an absolute mandate. So some vaccine is better than no vaccine. If you don't have access to the high dose vaccine, the regular would still work. For those of us taking care of children, it's important to remember that we cannot vaccinate less than 6 months old. And we'll talk about that in a second when we talk about adult considerations. But 6 months and 1 day, let's start vaccinating. The first time an infant or young child is vaccinated, so their first year, their first season, it's actually 2 doses of vaccine. It's to prime the immunity. And that's really important, although it's a little bit late in the game at this point. But I always remind people of this because if you're trying to time the vaccine and you have to give 2 that are at least 4 weeks apart, you got to start earlier because you want to get both of those doses in before the season hits. Talking about adults, there's an emphasis this year on vaccination and pregnancy, and that's where I want to pause for a second. It is at this point indisputable that pregnancy is high risk. So pregnant patients have a higher risk of severe complications of influenza, of hospitalization, and I will show you at the end of this, risks for their pregnancy. So we absolutely must prioritize pregnant women. We also have to think about the fact that you can't immunize the infant between birth and 6 months old. What else? Well, what can we do? So I think we can do 2 things. The first is we could take advantage of the fact that the placenta will preferentially transport maternal antibodies into the fetus during the 3rd trimester. So that fetus actually gets a boost to the immune system. They are being born with an immature immune system, not really well adapted or well strong enough, I should say, rather well adapted to respond to infections on their own right at birth. So we take mom's antibody, and this is something that the placenta does, and gives those antibodies across the placenta into the infant. Now, from an evolutionary standpoint, that makes a tremendous amount of sense because the germs that that infant will acquire right away are the ones that are in circulation in the community. So they're the ones that the mom has been exposed to in the weeks and months prior to birth, so their level of antibody should be higher. We take advantage of that with vaccination. By vaccinating in pregnancy, we can boost the immunity and transfer some of those antibodies. The other thing that I'm a proponent of is cocooning, which is basically the theory that if I can't vaccinate the infant, I'm going to make sure that every person around that infant, the caregivers, the visitors, certainly the household contacts, are vaccinated. The idea that we can keep the vaccine out of, keep the germs out of the home using the vaccine. So now we're going to try to convince people to take the vaccine. And there's going to be pushback because there's always pushback. And so it's important to be able to answer some of the questions that you can do proper counseling, that you can really convince people that this is in their best interest. So sometimes people will say, well, the vaccine's not effective. Okay. Well, I actually like that question because it means that people are thinking. And the truth is that sometimes it's not that effective. Sometimes it is, sometimes it's not. So these are data from the CDC. You have the flu seasons here, and you have the estimated vaccine effectiveness. And you know what? 19% is not good. Okay, 60% is pretty good. And you see that it varies. But if we're going to get involved in this, and I will show any patient this chart, but I said, but then, now we got to talk about what this chart means. So the way CDC assesses seasonal flu vaccine effectiveness, it is effectiveness against influenza-like illness. So if you get vaccinated and you wind up sick for 2 days with flu, low-grade fever, a little achy, that vaccine goes down as ineffective. And I disagree with that. However, I have to be clear, that's how we do the calculation. I disagree with that because perhaps you were actually high risk. Perhaps in an alternative universe where you weren't vaccinated, that infection resulted in hospitalization, in intubation, maybe even death. And so what the vaccine did was modify the infection to a self-limited illness where you had to take a couple days off of work, stayed home, watched TV, drank chicken soup. That's a win in my book, but it goes down as ineffective. And we have scores of data that look at that and say the hospitalization rates are markedly lower in vaccinated people, even those that are at high risk. The need for medication for treatment of influenza is markedly lower. So these vaccines do work, even though they're not completely preventing all aspects of the infection. And it's kind of like what we're seeing with the COVID-19 vaccines, but I don't want to go down that road and make this more confusing. The other thing that we have to think about is if we're using a vaccine that has different components, well, the effectiveness is really based on each component. How well did you match that up each time? And then on the back end, what percentage of total infections that year are due to that component? So historically, the H3N2 has been a difficult vaccine to design. It tends to be less effective in the antibodies that are formed. And so if you have a year that has a lot of H3N2, the overall vaccine is going to look less. But then I tell people the final point is, I still think something's better than nothing. So it's not like there's 100% effective vaccine that we're not giving you. This is the best we have. And so if I was on a boat and the boat was sinking and you handed me a life jacket and said, I don't know, maybe it's only 50% effective. It's not gonna hurt me, and I'm gonna put it on because I'd rather take a 50-50 shot, because if I go in that water without anything, that's 0% effective. And sometimes it really, takes that level of frank discussion before you realize that the patients aren't thinking of it that way. The other question I get a lot, and this year will be my answer to this for years and years to come, is what about the timing of vaccination? So sometimes people try to sort of game this out and say, well, I don't want to take it too early because what if it wears off? And the vaccine effectiveness data about wearing off over time are less strong, but it does look like the effectiveness probably drops about 10% per month. So yeah, I wouldn't want a vaccine in July either. But as we're seeing this year, you never know when that peak is going to be. So if you were anticipating a February peak and decided, well, I'm not going to get vaccinated until end of December, you're already missing out on a lot of protection. And these are data from the 80s till last year. What year was the peak? And you can see that across the United States, if you had to bet money, bet on February. But again, I'm hoping that this year is December. We'll have to see how the peak plays out. And I don't favor people really trying to game this out. Certainly in pregnancy, we're going to want to use one of the prenatal visits, and we want to shoot for early third trimester. If we haven't had it done before then, across all people, you can see that the data tend to favor vaccinating at time of availability. Because, like, for instance, in my clinic, the one that I work in that predominantly serves people living with HIV, if they're well and healthy, I see them every 6 months. And so if I'm seeing you in late September and choose not to give you a vaccine, I'm not going to see you again during the flu season. So now I have to rely on, did you go to the pharmacy? Did you come back in as a walk-in just to get the vaccine? It's much safer and easier to just give it when you have the person in front of you. We talk about risk, and we certainly want to prevent infection. But if there are infections, there are treatments. This is where I like to pause and talk about high risk patients. So who is high risk? Who is likely to have severe influenza? the extremes of age. And you see here, women who are pregnant or postpartum, this is directly from the CDC risk calculations. And so this is our group to talk about, yes, we want to prevent this with vaccine, but should you become ill, we would want to consider medical treatment. There are a bunch of drugs. Most people use oseltamivir. It has the best safety data in pregnancy. It's been around the longest and does decrease symptoms for a few days. You know, I keep hearing, obviously, this is what we're here to talk about, is vaccine in pregnancy. And these data have really stayed stagnant, and it really troubles me. If you think about it, if every person who is pregnant should be vaccinated, and we're only doing about 50-50. And they should be vaccinated because of their health. They should be vaccinated because it decreases the risk of hospitalization. Again, we were talking about neonatal immunity. The only contraindication is the live intranasal vaccine is still considered contraindicated in pregnancy. That vaccine is really not in wide use. I don't think that that is a significant barrier to care. Is it really true that pregnancy is higher risk? And I think the answer to me are conclusively yes. This was actually published, this is international data, or internationally published, was in 2022. So here they looked at just women who were of reproductive age in the United States across 9 different seasons. And what they were showing is, it's an interesting way to look at it, 28% of the women of that age group that were hospitalized were pregnant. And of that, 62% were in the 3rd trimester. So there was a disproportionately higher risk that you were going to wind up hospitalized with a viral respiratory illness if you were pregnant. They looked back, you know, there was an increased risk of premature labor, of fetal loss, and severe lung disease if you were pregnant. And the other one that I always, think we have to pause and remember is that risk doesn't drop miraculously right at the time of delivery. And so the increased risk does last for a few weeks postpartum. Thinking about, a lot of visitors to the house, perhaps, everybody wants to see the baby. You have to be careful if they're bringing influenza as well. These are the international data. This is, again, New Zealand, where they have a very robust public health system. They could really track all of this stuff. Over 822,000 pregnancies over a 15-year time period. And notice this is pre-COVID-19 times. There was a greater risk of preterm birth and low birth weight in the pregnancies that were infected. Vaccinating during pregnancy decreased the risk of preterm birth, decreased the risk of low birth weight, and decreased the risk of miscarriage. And so these two are two of many, many different studies that I could have shown you that really tell us we have to focus our efforts here. So how are we going to do this? I thought this was really interesting. So this is a little bit older data now, and admittedly, a lot has changed in the vaccine world. So I'd be curious if they repeated these now post-COVID. But they were asking pregnant women, what were their concerns, and how did they decide if they should get a vaccine or not? Now, this wasn't only influenza, this was Tdap, this was all vaccines. And really, what do we want to learn here? We learn that it's very important to be able to show that these are safe for the baby and safe for the patient. And it really does come down to adequate information. The same study showed that the number one source of information was the healthcare provider. It wasn't the internet, it wasn't friends and family. So I like to end on this because I think this is what we need to do. And we need to be able to give these information out in a way that people will understand, can be digested. And we need to be able to give a strong recommendation that says, yes, you need to do this. You will be better off for doing this. And it is very, very safe, not only for you, but also your unborn. Now, I think that we have a vast variety of experiences out there, and I'd love to hear from everybody, your thoughts and what barriers you might have seen for this. And we could, I hope, brainstorm all together ways to overcome them. And thank you for listening.
Thank you so much for that great presentation. We do have a couple questions that came into the chat. So one question was asking if you could please explain how long children are infectious with flu versus adults at the testing positive or symptoms onset. And with current outbreaks, many parents are questioning when it's okay to send kids back to school in group care settings.
So we use the week, the 1 week, and we want to see people feeling better and afebrile. Now, it's not really well parsed out for children, and I have to admit, every school has its own thing. Um, it is probably true because it's probably true with most viruses, and depending on how you look at it, children, especially young children, probably shed virus a bit longer. But usually, if we're at a week out and you're feeling better, in general, you should be safe going back.
Okay, thank you for that information. That's very helpful to know, especially I know a lot of kids are getting sick and they're out, and a lot of times parents are concerned on when they should send their
Yep.
child back to school. So we have another question asking about flurona. So is flurona a concern for this season, getting flu and COVID infection at the same time?
Yeah. So, I mean, I think there's two things about flurona, and that then I heard fluronasva, and like trying to jam RSV in there. Um, there are some data that co-infection, both viruses at the same time, can make people sicker. Um, that hasn't happened that much. Part of the reason is when we were seeing everybody getting coronavirus, there wasn't a lot of flu circulating. And so there is some concern about that. There's definite concern in the people who already have pre-existing lung disease, severe cardiac disease, things like that. I think that the bigger thing, and this is what we're really seeing right now, is those two infections, even if they're not in the same person, are really stressing the healthcare system. Um, one of my colleagues tried to bring their child to an emergency room, which is odd because I said, you too can write oseltamivir prescriptions, but they told me that there was a 300-person line waiting for influenza and coronavirus testing. Um, my concern is if high-risk patients, especially, don't do things to decrease some of their risk of severe illness, I don't want to go back to, ICU overflows and trying to talk about ventilator scarcity. So I'm more worried about both viruses circulating in a high level than I am the few people who are going to get both at the same time.
Thank you. We have another question asking, would you recommend there to be wider public health messaging encouraging use of antivirals for flu? There still seem to be some hesitancy in using them due to concerns about side effects, especially for parents of young children.
Yeah, that's a great question. Because right now, I agree with you. So the messaging has been in using antivirals for the highest risk patients. Um, there's there's some data, though not as strong, that using antivirals early could decrease your overall course of illness. We know that. Maybe make your shedding go away a little faster, which I think could decrease infectivity. Um, so I do think anytime I hear of somebody with influenza, I do think about should we give them an antiviral. So the way you asked the question, yes, I do think we should talk about that more and message that more. To me, the bigger issue that I haven't really seen as well addressed is the idea of testing, because I don't want to give out all these antivirals unless I know what I'm treating. And so COVID-19 sort of taught us everybody's got a bedside test in their nightstand. Wouldn't it be lovely if we had that for influenza too? Um, and I think about it not so much in the way you asked it, which I think is a great way to really think about it, but I think about it for my high risk patients. I need to know, is this influenza and I should be giving oseltamivir? Is this SARS-CoV-2 and I should be giving one of those antivirals? Is this RSV and I have nothing to give you, or adenovirus and I have nothing to give you? Because these antivirals don't all work. They're very virus specific. So there's not one catch-all. I'm thinking that we're going to get to a world where there's rapid use of very high sensitivity diagnostics, and we'll know exactly what thing we're treating. And I think that will change a lot of the treatment parameters.
Sorry, just trying to get the next question. Oh, it seems like it's a comment about, it seems like the messaging is very strong for COVID antivirals, but it's not but not at the same level for flu. So just a
I,
comment related to
I
that.
would agree with your comment. Yes.
I have a question. So I work a lot in the community, and it kind of seems like if by now, like people didn't get the flu vaccine, that it's very hard to like convince them or like give them the education to get the flu vaccine. Is there anything that you could recommend when talking to like a hesitant parent or maybe just like someone in a community about getting vaccinated for flu?
Yeah. I mean, and let me tell you something. I guess off the record, except this is being recorded. So we're seeing that in the hospitals too, even among hospital staff, coworkers. That you're right. There's this point of, where we're in the throes of the holiday season. If you haven't done this yet, there's some reason that you haven't done it yet. So going from that, I think it's individual dialogue, and admittedly, that's going to take time and effort, and it may not work right away. But I ask a lot of how come? How come you don't want the vaccine? What's the concern? What's the issue? And this is actually supported in the vaccine hesitancy literature, because it is very difficult to predict what someone's concern will be. And sometimes it's side effects, sometimes it's effectiveness. And I think things like this, where we all get the toolkits to be able to say, oh, well, actually, and then you could re-educate a little bit. The number one thing that I hear is, well, it doesn't help anyway. Um, and that's where I very much lean on, it really does modify how sick you could become. And as crazy as this sounds, since I really feel like the SARS-CoV-2 vaccines really reawokened or gave fuel to the anti-vaccine um, sentiment in this country, people are understanding the idea now that vaccines may not prevent all infection, but they stop you from getting very sick. I've switched a lot of my education at the patient level to, let's keep you from getting very sick. And I find that helps, because many times people will have even just some mild other illness, but they'll attribute it to the vaccine failed and will never want to take the vaccine again. So it really, unfortunately, though, I don't have a great answer for you, because it has to be an individualized set of counseling. And then the final thing that is very much in the literature, it may not work on the first time, but when you revisit that after they've had a week or two to mull it over, if you have the occasion or the opportunity to be able to revisit it, it can, you'll see these barriers start falling, because people will take what you've told them. They may go back, do some more reading on their own, and see that it sort of matches up, feel more comfortable, and keep that cycle going.
Thank you. Yeah, that's really important information because, like I said, I am a lot in the community and I try to do like basically what you said, like on an individual level, just trying to like understand where they are and meet them where they're at and hopefully be able to address any like barriers or concerns that they have
Yeah.
regarding like vaccination. So please continue to put your questions in the chat. I also just want to give information that we do have the partnership has a 2 Protects 2 campaign, which has patient education material for pregnant people about Tdap and flu vaccination during pregnancy. We also have videos on YouTube that's both in English and Spanish to provide education. Just looking through the chat, seeing if there's any more questions. We do have time for more questions, so please continue to put those questions in the chat. We have another question. Can you discuss the benefits for babies less than 6 months who are being breastfed? Is there any benefit for moms who are vaccinated?
So, that's a great question. The data are not that clear on that, and mostly because it's a really hard study. It's a really hard thing to study because you would need to find moms who were breastfeeding but then didn't get vaccinated versus got vaccinated. So a lot of it is just extrapolated from the general benefits of breastfeeding. And so we know that there are maternal derived antibodies that are transmitted during breastfeeding, especially right in the beginning, early breastfeeding. And influenza antibodies are included in that. So there should be a benefit. It's a reason to make sure that mom is vaccinated and her antibody levels are high. But I've never found a study where I can point to that, these group of people, and it showed you this percentage benefit, because again, there's so many different variables in that. I think that if you're making the choice to breastfeed for health reasons, certainly having the highest level of antibodies possible through the use of vaccine is a very logically defensible argument to make with the person, and saying, let's make sure your breast milk is as robust, if you will, as possible.
Thank you. So we have another question asking how can we get local health departments and FQHCs to have more clinics?
Oh, that's above my pay grade. I think you're right, but I think that's a very individual, local level that I don't know how to answer. I'm sorry. Is there anybody else on the call that could actually answer that?
I mean, I know for our program, we do reach out to like local health departments or other providers that we know provide flu shots and try to schedule events around that. So that is something that the immunization department does do. And I know I get flyers from other organizations that's doing similar work. So basically just like the people with the foot on the ground, like reaching out to these health departments and local FQHCs to provide vaccinations for the community, making them more available. Give a few seconds to see if anything else is coming in before we conclude the webinar, but I do want to thank you very much for taking out the time to give this presentation. Very important information. As we can see from your presentation, there's a lot of work left done to, you know, continue to spread awareness on flu and the importance of flu vaccination.
Thank you so much. And really, honestly, everybody on this call, thank you for doing the work on this. You know, it's very much needed and unfortunately not always verbally appreciated, but you're keeping everybody healthy. So thank you.
Thank you. And again, I would just like to plug in there that for the Power to Protect New Jersey campaign, if you look on your handout section, the updated toolkit was included in there. And also, if you go to our Power to Protect New Jersey website, you can receive updated information on things that we need to know for this flu season. And if there aren't any more questions, I would just like to thank Dr. Cennimo for taking out the time to talk to us today. Thank you.
Thanks. Have a great day, everybody.